with your analgesics. Now, sedation, mild sedation with things like midazolam and so on, can be used as tier zero. But really and truly, when you're talking sedation, you're talking most, not midazolam, nah, mild sedation with, oh gosh, I forget the drug, right? But when you're talking sedation, you're thinking tier two principles of management of increased intracranial pressure, right? So heavy sedation with midazolam and propofol. So the one they like to test you on for tier zero would be elevation of the head of the bed, all right, as well as um, ensuring that the patient is normothermic. Okay, so elevation of the head of the bed, the mechanism by which that decreases your intracranial pressure is to increase venous outflow from the brain. Okay, tier zero, tier one is where we're talking about things like hyperosmolar therapy with mannitol, right? So it increases osmotic diuresis. And tier two is where we have our heavy sedation and hyperventilation coming into play. So hyperventilation is where we have breathing, you're inducing a hyperventilation to allow the patient to become hypocapnic. When their carbon dioxide levels drop, that hypocapnia leads to cerebral vasoconstriction, and that is a means of decreasing the blood flow to the brain and therefore reducing your intracranial pressure, right? So just learn this off, know what belongs where. Remember that sedation is really tier two management, right? And implants in your brain, the means by which we can um control increased intracranial pressure or manage increased intracranial pressure. All right, so this is something just to place in your mind. Okay, and when we go back to the MCQ, we'll just highlight which of these steps, um, the mechanisms by which of these things reduce your intracranial pressure. Okay, so to conclude our lecture, the last part of the lecture would be the, the findings of abyssal skull fracture. Okay, so abyssal skull fracture has particular findings, and I've seen them bring this a couple of times, right? Raccoon eyes, battle sign, CSF rhinorrhea, CSF autouria. What? How do you know that fluid is CSF? How do you know that fluid is CSF? Fantastic, right? So you're testing for beta 2 transferrin. How else you could know without testing? Halo sign. Excellent, right? So beta 2 transferrin is one of the questions that they would have brought in a June paper, I think, right? So this is the test to determine that beta 2 transferrin is found in cerebrospinal fluid. Okay. The other findings of abyssal skull fracture. So we have raccoon eyes, battle sign, CSF rhinorrhea and autouria, anosmia because of breaking the cribriform plate and the olfactory bulb, hemotympanum, and the last one. Shucks. Guys, let me just put this charge here. William, how come in? Tell me my battery died anyway. And the last one, finding of basal skull fracture is that of they like to trick out this one is which cranial nerve palsy, and that is cranial nerve 7. So I was really impressed that you all got that one. Cranial nerve 7 palsy. Right? So the findings of basal skull fracture, they tend to test that and they like to test beta 2 transferrin. That's how you know definitively that the fluid is CSF. So raccoon eyes is what we call periorbital ecchymosis. So it's around the eye. Periorbital ecchymosis, and battle sign is retroauricular, behind the ear. Right? Retroauricular ecchymosis. Good. And I do have pictures in my guide of that, right? So this is battle sign, this is raccoon eyes, all suggestive of B-cell skull fracture. Okay? And that's what this is here. All of this here is B-cell skull fractures. Okay? How's that? Good. Honestly, neurosurgery is very low yield. You might get 1 question to 2 questions on neurosurgery. And it tends to be on your head trauma, your ICP management, or B-cell skull fracture. Really and truly. Like that's where it tends to be. So once you know these things, you're pretty good to go for most of your neurosurgery. Okay? Any questions on those things? Let's wrap it up. Once no questions. Okay, so no questions. So this is our final sets of, thank you, Alia. Final sets of questions in our formal teaching, and it saddens me because our course has come to an end. Going forward next week, it'll be for you guys to show me that you all have learned a lot, and we'll just be revising. Yeah, time did indeed fly. So let's wrap it up before I get sad and start to cry. Right? So 20-year-old cricketer hit at the side of his head by a cricket ball while fielding, and he has a brief loss of consciousness. Returns to the ED. GCS is 15. But he has a severe headache and blurred vision since regaining consciousness. He has a right-sided pupil that is dilated, and right pupil dilation is suggestive of what? Why is his right pupil dilated? Anybody? Why is his right pupil dilated, man? Let's just say he got hit on the right side of his head. Yeah, come on, cranial nerve tree compression. Come on, guys. The same thing. Same thing as if we have an acute cranial nerve tree palsy. What did we say it was? Patient 60 years old, never had a cranial nerve 3 palsy before. Now, suddenly they have, over the past week, new onset cranial nerve 3 palsy. What did we say it was? Or what do we have to rule out? Yes, space occupying lesion, but not just that, Sydney is acute. We have to rule out PCA. So I guess then you're saying PCOM aneurysm. Yeah. So yes, a posterior communicating aneurysm. We said acute cranial nerve tree palsy because of where the posterior communicating artery runs. Once you have an aneurysm there, you could have compression along the oculomotor nerve. So that's a risk factor for subarachnoid hemorrhage. So when you see a patient with an acute onset cranial nerve tree palsy, what investigation are you going to do? Okay. But more specific than that. Okay, so it's not the answer is not a CT brain. Yes, you'll do a CT brain non-contrast, but you have to be thinking something else. Carotid angio. I would you look at it? Yeah, CT angio. So what angio? What would you write on the X-ray request, on the radiology request? What are you gonna send to the radiologist? You are my intern, and I say, I teach you, boy. And you was in my class. This patient have acute cranial nerve tree palsy. Write up that radiology request for me. What is your requested investigation? What are you going to write for the radiologists? Okay, it's an angiogram. Good. What are you going to write? So that's good. We get to that point. Oh, okay. Well, let's go quiet, boy. So there's an angiogram. It's very easy. You want a CT cerebral angiogram, right? So you want to look at the blood vessels in the brain. Okay. So that's for an acute cranial nerve 3 palsy. Anyways, so this guy has not because of a posterior communicating artery aneurysm, but because of an expanding epidural hematoma, he has cranial nerve 3 compression, and that's why his right pupil is dilated. All right. So a CT scan is performed on the basis of those findings, and it shows you the lens shape extradural hematoma, which of the arteries is injured. Um, that will be the B, middle meningeal artery. Okay, middle meningeal artery. So B is the answer. Okay. Good. Number 15. So which of the following sets of clinical signs are usually associated with a basal skull fracture? Well, we said periorbital ecchymosis, otorrhea, CSF otorrhea, retroauricular ecchymosis, which is so periorbital is raccoon sign, CSF otorrhea, retroauricular ecchymosis is battle sign, and we said the cranial nerve is a cranial nerve 7 palsy. And this is what they like to check you. They bring cranial nerve 6, they bring cranial nerve 3, etc. But it's actually a cranial nerve 7 palsy. All right. So excellent. 15 is A. Right. So number 16. This is a man, 34-year-old, after TBI, traumatic brain injury, following a MVA, motor vehicular accident. His CT scan shows contusion and swelling, but no hematoma. So a ventriculostomy is placed for invasive monitoring of the intracranial pressure. So we have invasive intracranial pressure monitoring because he has cerebral contusions. And we realize his pressure is high, and despite elevation of the head of the bed, despite sedation and therapeutic lumbar puncture, his intracranial pressure remains elevated. So now we want to try hypocapnia. So hyperventilation, how would this aid in decreasing the patient's intracranial pressure? Hyperventilation. So I'll just write it down for you guys because I know sometimes you will take pictures or whatever. So for hyperventilation, what it does is that it induces hypocapnia, and that hypocapnia would ultimately lead to cerebral vasoconstriction. Okay. So that is that. We said that increased venous outflow from the brain, the mechanism of managing increased ICP that does this is elevation of the head of the bed more than 30 degrees. We said therapeutic lumbar puncture is what decreases your CSF. We said sedation is what would decrease our metabolic demand and control hypertension. And we said mannitol is what induces osmotic diuresis. All right. So hyperventilation aids in decreasing intracranial pressure by inducing cerebral vasoconstriction. So D is the answer here. And number 17, well, I'm not gonna do this whole thing, but let's see. All right. So this girl, she opens her eyes when her name is called. That is 3. She's talking about her studies, so she's confused. So that is how much is that? 4, right? 3 and 4 is 7, and she winces when you press her nail bed. So this part of the question kind of tricked me, but then when you watch the answers, you realize it could only be now 11, right? Because she got 3 for eyes open, she got 4 for being confused, so that's 7. And if you were to give her 2 for wincing, it means that that's abnormal extension or decerebrate rigidity. So it's actually not abnormal extension. The only thing it could be is with flexion in response to pain, and that's a very weird way of saying that, right? So this is actually 11. She got this wincing when you press a nail bed is what gives her. So the score here is 11. All right. So good job. All right, everyone. That concludes our teachings. Are there any questions? So I am. This week is mock exam, and I want to send out everyone's work I'll be going through. I have 96 of you. I'll be going through everyone's chat individually. I'm going to take my entire day to do it tomorrow because it's my first day off in a long time. And I will address any of your questions, queries. I will try to. There are people who send homework late and I'm waiting answers. Don't worry, I have all the things. You all are in my archive. So tomorrow and into this week is 90 something of, right? So I'll try to reply to everyone's concerns as best as I can. Um, Concerning the endocrine and heme and renal work, you will get those answers definitely before the week is over. And people who would have sent me homework late, you will get the answers when I reach in it, right? Um, Mock exam is this week. For those of us who are not here, the process by which we do the mock exam is we do it on our own at home. I am only teaching medicine and surgery. I am not going to have any guides. It is the purpose of the mock exam. My course is finished, right? I've done what I can do to give you all as much as I could. The purpose of the mock exam is strictly recap, and wherever I might have left out something, I will be speaking from the top of my head. So it is basically extremely important to pay attention. I will be writing on the screen, but everything will be off top. It would not be guide based. It will be, hey, I feel like I should teach you all this because I feel like my brain remembers this from. All right. Where the PEDS, Psych, and ONG are concerned, I will just be giving you all the answers. The purpose of those questions is to guide the topics that you study and to familiarize yourself with how the exam feels in terms of switching from subspecialty to subspecialty. All right. So that is it. If you all have any questions or queries, my sign-ups for the OSCE, well, people basically already signed up. So um I will send out receipts and things to those of you who have already paid, and we'll talk OSCE when OSCE comes around. But thank you so much, everyone. This completes my final class. This actually is my final official class, right? So thank you, everyone, for paying attention. I can guarantee that you all who are honestly answering my questions, you have no fear. You have already passed the exam. Just go for the distinction now. Had a fantastic time. This is the first time I taught with drawing and all of that kind of stuff, and I think it really enhanced the experience. A lot of students were appreciative of it. I can't draw and I cannot write, but somehow you all seem to grasp concepts better. So thank you for being for always participating and being attentive. Um, we'll finish off strong with our mock exam, and that'll be it. Yeah. So thanks everyone. I'll see you guys on Monday for mock exam one. Yeah. Take care. Sure. Thank you all. Thank you.